So
So tell me a little bit about, I wanted to talk about something that's not too sexy, but it's like ugly toenails.
I love
So,
ugly toenails.
so tell me in your mind, Scott, like, let's talk about a fungal toenail, maybe a traumatized nail that's thickened,
Yes,
and then a lytic nail that's on with onycholysis that's lifted, and
right.
they want to get it to reattach, or they want to know if it's fungus. Like, how do you, what's your methodology?
Well, my most success is with the actual infection to the nail. Um, I have not had any confidence in actually reattaching a nail plate. If it's fresh and you remove it and clean it up and you keep it moist and dressed, then I think it has a good chance of reattaching. If it's a chronic onycholysis, I haven't. I mean, I've tried to rough up the bed, really irritate it and try to, right at the leading margin. But no, I don't think I don't think I have any keys for that.
Okay.
Um,
I'm just hoping to ask. Eventually, I'll talk to someone that does. Because I don't either, Scott.
I don't have any keys for that. And a nail that's truly traumatized, I don't think I have a really good answer for that, other than maybe Onifix. If it's something that's we've had good success with Onifix with incurvated nails because it helps flatten them out. But if they're, the nail that's really wavy across, no, I haven't. I mean, you can buff it and put a clear polish on it or something like that and make it look good. But as far as making that come out normal, to me, that matrix has been damaged and it's just done.
For your Onifix, how often do you do it?
We're fairly new, so I'm having them come back at 2 months, even though the company says 3 months. And we just verify it. If it has grown out sufficiently and they need another band, we'll do that. If not, we'll just see them in 2 months and reapply a band at that point. We haven't had a single complaint with it, but again, it's fairly early on.
Yeah.
That. So
I've done about 50 of them, and
you've done more than me.
Yeah, the only problem has been ingrown toenail, which is obvious, and that's the reason we're doing it. So I snip it out, and some I have to transition to a matrixectomy. But these are people that just want to try this before they do a matrix.
Yeah.
And I've used it for some onycholytic nails too, proximally, to see if as it stabilizes the nail, it might grow out. And I give that as an option. So sometimes it can help it to stabilize it, sort of reattach. I'm not totally sold on it, but I'm trying it.
Have you had any success with that?
Gosh, I don't know. Because I haven't done it on a ton. It's mostly I'm doing it on ingrown toenails. I'm offering it to try it. But tell me about your protocol with So I send it to a local lab for nail fungus. I take a distal trimming. Sometimes it comes back with a PAS as fungus. I don't routinely check for bacteria. And all I would do is I usually do Lamisil for most of my patients. I do it 3 months once a day, 6 months once a week, and then if need be 3 months once a day, and they're doing biotin. So how do you do it?
I knew that we were going to talk about this, so I brought a little order form. Mm-hmm. I have no financial obligation with these people, but let's see if I can line it up.
I can see it there. Yep, Microgen.
We started using them 6 years ago, I guess, and our world changed completely with nails. 85% come back with bacterial infection, and you alcohol the nails off really good, let them air dry, so you clean them up, then you take the sample and send them in. And so if Lamisil is advertising that they get roughly 13% success rate across the board, well, and if the lab's saying they're getting 85% contamination with bacteria, well, Lamisil is not responsible for their failures for the bacteria. And if the nail's not improving, then it's just not improving because it's the bacteria. And so then we started getting those results, and we use a local pharmacy that's very committed to compounding, and they will make up a compound oil that people paint on twice a day. They file their nails down thin and just apply that twice a day. It's a slow process, and sometimes we will, depending on what the culture comes back at, we'll add the oral Lamisil as well.
And so what's the difference? What your results?
I haven't actually done the math on it, but it's
working a lot better than it was with just oral Lamisil, right?
unbelievably better, just unbelievably better. Yeah, 4 or 5 fold, 4 or 5 fold better than just the Lamisil alone. And the tea tree oil and stuff like that never really did much for us.
Yeah, I have one that I dispense here only because it has a money back guarantee. Not that I believe in it. Some people want it. Now you can try it, but I don't believe it works that well.
And it could be that the people that are using the tea tree oil and what's the other stuff? The Vaseline and the Vicks, and on those that it truly helps, I probably don't see those people.
Well, of course they're gonna watch it on YouTube, and it's probably a superficial case that'll get better on its own. We're just seeing the really bad ones. I like that idea of doing bacterial. I'll see if my lab can do bacterial. We use a compounding pharmacy for some other stuff. I never jumped on the bandwagon. Everyone, I just think they must get paid a lot for these compounds. That's why they do it. I don't know. It's so popular these days.
Well, some pharmacies will try to promote and encourage, and they'll bring a podiatrist on as a in-house consultant or something like that. And there's a pharmacist in jail in Oklahoma for he was cheating pretty good, and some of the podiatrists and other family practitioners were involved, and there was kickbacks, and that's not a good place to be. So I don't have any association with that kind of thing, but not all pharmacies can make this up.
Wow.
So
well, I like the idea of trying, and so for those that are listening, I'll put in the description. Maybe you'll just send me kind of what's the compound, what it's made out of, and
I'll send you my script.
Yeah, send me your script, and if people want to make something similar, if it's compounded, anyone can make it. You could give it a shot. You do it for everyone that has nail fungus?
Everybody that wants to treat it. Not everybody is willing to paint their nails twice a day.
Yeah,
and it's a slow thing. So,
and is it do you always do it with Lamisil or only sometimes with Lamisil?
Everybody gets Lamisil topical.
Okay. I'm sorry, Lamisil, not oral.
Right. Everybody will get Lamisil in the topical. Even if I get a culture back that has no fungal infection, it's just so prevalent that I just include it in the script anyway. And they probably only take it 1 pill.
And grind it. I remember we used to do that with Gordochrome. Remember, you grind it up with Gordochrome?
Oh, yeah. Yeah. But I'll send you the script pad, and each script that we're writing is really, there's some pretty common ones, but they're modified based on the culture that comes back, and we change the compounds around. So, I'll if you give me your email, I'll send that. And,
no, that's good. I'll email it to you afterwards. So what other things that I don't know. I think we all have things like, for me, these checklists and these treatment evaluators make my life a lot easier. And I wish everyone knew about it. Are there other things that are working really well for treating common podiatric things that you're doing? That
nurse. My nurse works very well. She's been here 14 or 15 years, and she's an RN, and I've been able to be a little lazier because she's so sharp.
Yeah.
And she will say, hey, what about this? You told me that you wanted to include this, or and so she's just sharp like that. She is on top of it, and she will so having good help, because I get distracted, there's a lot of things going on, and I might not remember something I really did want to do. And she is just on top of it. So I think that help is probably the most important thing for me.
That's good. Do you use
Yeah,
a scribe, or do you type your notes, or what do you do?
we type our notes, but all our notes are done when we walk out of the room. It's it's just done, and she does the majority of it. And we have 2 hours in the mornings where she can prep all those notes, and if we schedule correctly, we know who's coming in and what the deal is. And unless something comes in different, of course you don't know about the new patients, but um, and she just kind of preps that in advance, and the day goes real nice.
That's good. So tell me about we'll talk about nails. It's not too exciting, but a lot of us do it. When you're treating a nail fungus, I usually see them back at 2 weeks just to go over the pathology results, maybe order LFTs, and then I see them 3 months later, and then maybe 6 months. Is that kind of, how do you kind of do it?
The same thing. I just want to make sure that because they're not changing fast with your treatment. And so I just like to make sure that we're not having a inappropriate reaction, because there is urea in that compound. And I've had a few kind of nasty responses, but it's just really basically just make sure that they're doing well. And then after that 3-week check, then that's 3 months.
Yeah.
And then 3 months, and then 3 months, because it is a slow deal.
And then so it takes about a whole year, right? You wait for the whole
Oh,
nail to
yeah.
come out.
Yeah.
And then after that, they don't need to use the compound anymore, right?
I try to have them use it intermittently, just
Mhm.
as a maintenance.
Okay.
But most of them kind of quit. It gets pretty fatiguing
Oh
on them.
yeah. Oh yeah.
So I mean, how many times I don't always do my physical therapy on my shoulder just because I get lazy. It's not really bothering me that much. So
Yeah.
why do I think about it? But I don't. So
I heard a good quote. I was in this derm lecture, and they said, the number one thing you can do to make your patients use the topical or whatever you're telling them to do, or any exercise, it's you increase the frequency of your visits. If you see them every 3 days, they're more likely every week, every 2 weeks. And so the reason you do it sometimes, like I a lot of times see someone for plantar fasciitis, and then 2 weeks later, only to make sure they bought the new shoes, got the over-the-counter inserts, scheduled their physical therapy, and I'll make sure they do it in 2 weeks just to keep them accountable. I think we get paid a lot of times just to keep them accountable to stuff.
there's a lot of truth to that. I would be curious. I know that you do some stuff, and if you're done with the nail thing, I know that you do some stuff with intermittent fasting.
Yep.
And I went to the family practice guys at the hospital. We're all sitting around eating and wasting time at the hospital between cases. And so I just asked them, I said, so what do you guys do for helping people lose weight? Their response was very telling. They just started laughing in unison. And so I said, what do you mean? What's the deal? And they said, so you're in private practice. You want people to come see you, and you want to tell them something they're not going to do, and you're just going to make them mad. I'm like, no, I'm trying to help them, lose weight, because we have a real high population of obesity, and that does not help feet. And so I was curious what they do. They don't.
They don't do anything.
They don't do anything. They don't talk about it. They don't. Now, if a patient asks, you bet, well, here, let's go to the nutritionist.
So what I do, and the reason I got into this is I always go back like what's the cause? So people come in for foot pain, and I ask them, well, how'd you injure yourself? 80-90% they're working out. And I ask, well, do you like to work out? And they tell me no. And I said, well, why are you working out? And then it goes back again. And well, because I want to lose weight.
Yeah.
And I'm like, oh, so you wanted to lose weight, you're working out, and you hurt your foot. Okay. So if I really want to help them, I try to help them with weight loss. Now, I am not a weight loss doctor, but I've been intrigued, and I kind of use myself as a test kitchen.
Yeah.
And so I have a page on my website, drpelto.com/diet. So if anyone wants to look at it,
Yeah.
and I basically, I share that page with my patients.
Yeah.
And I've done a lot of lectures at the libraries here, and they've asked me to do lectures, and they're like really well attended. And,
That's cool.
I'm looking for someone locally that I could refer them to, because my success rate is I usually have 2 patients a year that lose between 60 and 100 pounds.
But that's impressive.
And they come in and they actually do it. And I have a whole like PDF of how they do it. You start with 12-hour eating window, you do a 16-8, then you do a 24. And basically my thought is, if you want to lose under 30 pounds, you do 1 meal a day, Monday through Friday. If you want to lose over 30 pounds, you do alternate day fasting.
Yeah.
I tend not to tell them to do ketogenic diet until they get the fasting down. So one change at a time. Once they get confident with the fasting, then they can do ketogenic. Usually their confidence is built up that they want to change the way they eat. And then after that, then they can work out. Not a lot of them are big takers, but sometimes I see them back just to go over that with them and help them. What works for you?
Well, I don't know that anything really does work. I know that me and my daughter are working on intermittent fasting, and that works. But as far as patients, I try to get them off of the treadmill, off of the trying to jog around the block, and get them into water walking.
Yeah.
Because
less impact.
Well, yeah, they're over 300 pounds, and the last 20 years they've been completely sedentary, and their system is just not designed to do that. They're just not up for it. So if they can go water walking, they'll burn a ton of calories without the damage. And so we have a few people that will follow that, and most don't.
I know, Scott. I always say I usually I do it. It's called like motivational interviewing. I kind of say I kind of see how motivated they are, and I send them the resources, and I say, well, if you read the book, which is the obesity code, we'll talk about it next time. So I can gauge their motivation level, and then when they come in, then I'll say, you might want to go to the Life in the Fast Lane, which is or a diet doctor or one of these other ones to get information or get coaching, because everyone's different. Some need help, some need coaching. I don't think a nutritionist, I don't agree with them, because they're talking about like 6 small meals a day.
Yeah.
It just doesn't work for me.
Well, it doesn't work for them either. I've been in a lot of places, and I rarely see a thin nutritionist.
Yeah.
Come on, think about it. If you guys are out and about around the country, if you've got a stack of thin nutritionists at the hospital, then you are an exception.
Yeah. And it would be, so I don't tend to refer to them. I would, my druthers would be, if I had someone that I could refer them, that they would give them like a free coaching session, and then do a group coaching program with my patients. That's what I would like. I haven't found out if that exists, but that would be the best thing, I think, because they need accountability, almost like AA.
Well, you just said that, and when I was talking about nutritionists, it occurs to me that I've only seen a couple of heavy sports physiologists, and I wonder if sports physiologists would be willing to counsel. Instead of a nutritionist, because they seem to always be very well
informed in what's the latest.
Yes, and they're paying attention to the body, and they're in good shape.
Cool. Well, Scott, I'm going to end this interview here. I'm going to end it here because I got to go see some patients, and thank you. And I'll put the information underneath this video. All right, and I'll send it. I'll fax it to you. Okay.